Hi everybody, my name is Liz Arias and today's topic is therapeutic hypothermia in diseased organ donors and kidney graft function. Definition. Therapeutic hypothermia, also termed therapeutic temperature management, is an established intervention that is used to protect neurologic functions in patients with certain types of cardiac arrest, stroke, and asphyxia.
When the heart decides to not function correctly and we need to do CPR in order to get it back beating normally, we have decreased blood flow to the brain. And that's when people become anoxic, they don't have enough blood flow to the brain, and it can adversely affect their brain function forever. So by using therapeutic hypothermia, we are slowing all that process down, slowing down the metabolism for a full 24 hours, and then rewarming slowly to allow the brain to restart and hopefully come back to its normal functioning state. We try to get them cooled rapidly within 4 to 6 hours after they've had return of spontaneous circulation. That's the first phase, which is the induction, which goes very quickly. And then the maintenance phase is the second phase, and that usually lasts 24 hours. We do keep somebody chilled at 33 degrees Celsius for 24 hours. Following that, we start a 16 to 20 hour rewarming phase. We rewarm slowly because that seems to help the brain slowly recover after it was without oxygen, which all was involved with the cardiac arrest.
Applications in medicine. The effect of therapeutic hypothermia on renal protection is uncertain. However, in a retrospective study involving patients with cardiac arrest, mild hypothermia appeared to protect against renal injury. An experimental study involving rabbits showed that rapid cooling to moderate hypothermia preserved the renal function during cardiac arrest. A review article summarized that the mechanisms for benefit with hypothermia. These include reduced metabolism and reduction of free radical production.
Hi, I'm Dr. Peter Antevi, and here for another edition of the Antevi Minute. Therapeutic hypothermia has been a hot topic for both adult and pediatrics, but there's something about the pediatric guidelines that we should probably look deeper into the science about. Let's take a look. And so I'll show you two studies, and then I'll show you the guideline recommendations. The first study was a positive study looking at 42 children. The hypothermic group had a significantly increased survival to discharge. Their neurologic outcomes were better, but not statistically better. So this was a positive study published in 2013. The THAPCA trial, which was a very large out-of-hospital arrest trial, you can see here that although it seems that the hypothermia group did better both for survival and good function, none of these numbers were statistically significant. So that's a very interesting point there. So what did the guidelines do? They said this was a negative trial.
Now, pros and cons. Pros. Hypothermia significantly reduced the odds of delayed graft function. Mild hypothermia reduces the rate of delayed graft function among recipients. The mechanisms for benefit with hypothermia, these include reduced metabolism and reduction of free radical production. Cons. Ischemia perfusion injury during the transplantation process is a major contributing factor to subsequent poor allograft function. Such an approach may be less successful in organs from expanded criteria donors, which already have an increased risk of poor post-transplantation functioning owing to chronic disease in the donor. Increased health care expenditures are decreased long-term graft function. Now the issue applied in Ecuador. Therapeutic hypothermia is used in particular cases where it is sought to protect the brain from possible damage produced during the cardiac arrest. It should be applied only in hospitals that have the necessary infrastructure and, in addition, be managed in a multidisciplinary manner. Now, this is a video that shows how it is placed in patients.
If your brain is not getting oxygen, your heart's not beating, you are essentially no longer alive. And without intervention, you would definitely not survive. Aggressive CPR and ice is what brings them back to life. The body and the brain almost attacks itself, and it becomes a worthless organ. And so our goal is to say by slowing down the metabolism, by taking the body down to really cold temperatures, we can prevent the body from doing that. Hypothermia also decreases the size of heart attacks. So even these patients, many of them are having heart attacks. That's what caused them to go into cardiac arrest in the first place. We know that by chilling them and cooling them, we're also minimizing the size of the heart attack itself. Rather than be a massive heart attack, maybe we can keep it down to being a submassive or a smaller heart attack. If you come into that state, while before we would say it's 5% chance you'd survive, less than 5% chance that you're going to have neurologic intact, now we can say if you've made it here and have survived to that point, there's maybe as high as a 1 in 2% or 1 in 2 chance or 50% chance that you might be able to have good neurologic functional return. That's much better than the national averages, so we still quote the national numbers, but I do think that we're onto something.
Conclusion. Mild hypothermia as compared with normothermia in organ donors after declaration of death according to neurologic criteria significantly reduced the rate of delayed graft function among recipients. And the last video.
After kidney transplantation, delayed graft function, defined by the need for dialysis within 7 days after transplantation, affects up to 50% of renal allografts obtained from deceased donors. While therapeutic hypothermia is an established intervention used to protect neurologic function in patients with certain types of cardiac arrest, the benefits of hypothermia for renal protection have remained uncertain. To investigate the role of therapeutic hypothermia in this setting, the authors randomly assigned organ donors after neurologic determination of death to one of 2 targeted temperatures, 34 to 35 degrees Celsius, the hypothermia arm, or 36.5 to 37.5 degrees Celsius, the normothermia arm. Temperature protocols were initiated soon after donation was authorized and ended when organ donors left the intensive care unit for organ recovery in the operating room. During the trial, 572 patients received a kidney transplant. Delayed graft function developed in 39% of those in the normothermia group as compared with 28% of those in the hypothermia group. The study was terminated early after a pre-planned interim analysis showed that hypothermia was associated with a significant benefit. This trial demonstrates that inducing mild hypothermia in deceased donors before organ recovery lowers the rate of delayed graft function in recipients. Full trial results are available at nejm.org.
Thank you.